All right, good afternoon, everyone. I see it's 4 o'clock on the dot. We've got quite a few people already joining. So I'll just start with the introduction, and then we can get the session going. So welcome to this afternoon's deep dive session presented by the University of the Free State. I'll be chairing the session. Dr. Stephanie Kennedy will do the bulk of the presentation, and Dr. Caroline Steyn will have a small intercession with a case relating to the topic. So just some housekeeping. If you've entered through the link, the CPD points are assigned after 60 minutes attendance. And that's handled automatically if you registered through the link. And you're welcome to please send feedback on the session to the admin at bloodsa.org.za, or any feedback we welcome. Put your questions in the chat box, or if we have the time at the end of the presentations for discussion, you can put up your hand and unmute and ask your question. But yeah, please feel free to ask questions and engage on the topic. So without further ado, I'm going to hand over to Stephanie. Stephanie is a registrar at hematopathology at the NHLS at Universitas Academic Hospital. She is originally from Bloemfontein and has been a student at UFS for 12 years. She also have a music degree, BMUS, from University of Free State, MBCHB, and an MSc in internal medicine, University of Edinburgh. And you can see there all of them are cum laude, so she's a high flyer. She gave this talk to our academic meeting a few weeks ago, and I think we sort of said that it's really useful for the general hematology audience, and asked her if she would be willing to present the talk on this forum. So with that, Stephanie, over to you. You can start sharing your slides and start the presentation.
Thank you very much, Jock. Thank you for the kind introduction, and thank you to UCT for the opportunity to present here today. So as you have seen by now, the talk is called The Small But Dangerous Clone, and I'm going to do what my colleague Gideon did last time and ask you guys, what is this talk about? And there's a poll that you need to answer. So I just want to make sure that you're actually seeing my screen while you're thinking.
Not yet, Stephanie. I think you should just reshare it, okay?
Yes. Okay.
Jock, Khadinje, can you see the poll responses?
I can see the poll responses, okay. Yes.
Okay.
So I think so the winning, so there's been a sort of a spread of responses. MGUS, monoclonal gammopathy of clinical significance. Nobody is 28% chose MGUS, 13% monoclonal gammopathy of clinical significance. Nobody's gone for monoclonal gammopathy of renal significance. Cold agglutinin disease, we've got 2 responses. POEMS syndrome got 1 response. All of the above, 42%. So that's the majority. And then, 1 response for cloning babies and 1 for Star Wars. Let's see what this is about. I actually hope it's about. It would be interesting if it's about Star Wars. But let's see. Stephanie, you can you can go ahead and tell us what small and dangerous clones are.
Thank you. Well, most of you had it right. So actually, anyone who didn't choose G and H answered right. This talk is about all of the above. I just want to double check. Are you seeing full screen now, Jock?
No, Stephanie, we're seeing your screen. We're seeing that, yeah. So share. Are you on a dual screen system?
Yes. So on my side, it's full screen, but I actually see.
Yeah. So what I think, stop the share, and then instead of sharing the window, share the whole screen. So maybe just cancel your share, and then share the whole screen that's showing your presentation.
Oh, the way I shared was wrong. Okay.
Possibly. We'll see.
Okay. Entire screen.
Yeah, share the entire screen, and then it's usually not the. And then go to your slideshow on the. Yeah, and maybe just switch presenter and slide view, and then click on hide. Now we can see. Great.
Great. Okay. So yes, as I was saying, all of the above is right, and today is a very, very cold day all over the country, so you should be watching out for those cold agglutinins, and that is at the very, very end, and we'll watch the time and see if we're going to include that or not, because it would be very nice if we had a nice discussion and enough time to do so. So without further ado, the subtitle really is MGUS, what's the significance? Why does anyone care about MGUS? So it may or may not progress to multiple myeloma or related conditions, such as lymphoplasmacytic lymphoma, AL amyloidosis, and it may or may not be clinically significant. So we're going to try and put it into context. So the aim of the presentation today is to answer these two questions. Who will progress, and when is MGUS clinically significant? So the first part is all about MGUS and who will progress. So what is MGUS? There are three different types: non-IgM MGUS, IgM MGUS, and light chain MGUS. Very simply put, the definition is that you have an M protein, paraprotein, call it what you will, but this paraprotein is small in quantity. It's less than 30 grams per liter. That's the unit we and the British use. You will see often in American literature they use gram per deciliter, then it will be 3. Or if you don't have an M protein, then you have an abnormal free light chain ratio. You also have MGUS. MITS, or on the condition that you don't have more than 10% clonal plasma cells in your bone marrow, and you don't have any slim crab criteria or symptoms of lymphoplasmacytic lymphoma or target organ damage of that, or AL amyloidosis. So essentially what we're saying is that you have a small clone that is not dangerous, or is it? And why is it called MGUS, monoclonal gammopathy of undetermined significance? So to answer that question, we quickly need to look at the development of monoclonal gammopathies. And at this point, I just want to kind of add the disclaimer that myeloma and Waldenström macroglobulinemia are very different conditions, but they have these precursor MGUS lesions. So here we're going to talk about the development of myeloma. This is a very good picture illustrating how multiple myeloma is basically always preceded by MGUS. And it all starts off with a small clone of plasma cells that secrete a monoclonal immunoglobulin. And over time, this plasma cell clone grows in size until it's large enough to cause end organ damage. And by that time, you have symptomatic myeloma. And if it's really bad, it can spill over into the blood or extramedullary sites. So basically what has to happen is you need to move from normal to MGUS, and then you need to move from MGUS to myeloma. So to move from normal to MGUS, there are primary cytogenetic events that occur, and to move from MGUS to myeloma, there are progression events or secondary genetic events. So the primary genetic events that are found in almost 100% of myelomas are actually already present in MGUS. And these are the hyperdiploides, which are represented by about 50%, and the other 50% is when the immunoglobulin heavy chain is translocated to an oncogene. And these are usually almost always mutually exclusive. You don't have both. So the immunoglobulin heavy chain is translocated to an oncogene, and this is then overexpressed by a mechanism called superenhancer hijacking. And this occurs as a result of normal B cell development. So by the time the B cell reaches the germinal center, it undergoes somatic hypermutation or class switch recombination. And these are quite error-prone mechanisms. So double-stranded breaks occur, and if there's an error there, this can lead to the development of a clone. So these are the primary genetic events. The hyperdiploides is usually a trisomy of one or more of the odd-numbered chromosomes. So we skip chromosome 1, 13, and 17. Whereas the immunoglobulin heavy chain translocations is usually to one of its 5 most common partner genes, and these are on chromosomes 4, 6, 11, 16, and 20. And this leads to overexpression to the genes listed in this table, which really directly or indirectly leads to overexpression of cyclin D1, cyclin D2, or cyclin D3, which are very important in regulating the cell cycle. And if there is overstimulation of the cell cycle, there's essentially decreased apoptosis, and this clonal proliferation is allowed. So the secondary genetic events are more complex, and they take you from MGUS to myeloma. So other translocations can occur, and these often involve the MYC gene. So the MYC gene can be translocated to the immunoglobulin heavy chain or one of the light chains, lambda or kappa, or other partners. And then very important are the copy number abnormalities, commonly involving chromosomes 1, 13, 16, or 17. So as you can see in this picture, there are very important genes located on these chromosomes. So chromosome 1 loss of 1p or gain of 1q is very common in myeloma, and important genes here are, for example, CDKN2C. If you have a loss of 13, DAL13, as you can see, you lose the very important retinoblastoma gene, which is very important in the cell cycle. Chromosome 16 contains the MAF and cyclin D1 genes, and then the infamous chromosome 17 contains the TP53 gene, which will be lost with DAL17P. So there are somatic mutations in myeloma, about 30 of them, which vary from patient to patient, but they all play very important roles that ultimately will lead to decreased apoptosis and increased proliferation of the clone. So for example, if your TP53 or retinoblastoma genes are mutated, the cell cycle is again dysregulated. Or there can be increased signaling in the MAP kinase pathway, with the most common mutations in myeloma actually being the most common somatic ones, being KRAS or NRAS. The NF-kappa B pathway is also dysregulated when TRAF genes are mutated. Not only is MYC involved in translocations, but this pathway can also be overstimulated by mutations. Epigenetics plays an important role in myeloma, most commonly DNA hypomethylation, but focal hypermethylation can also occur, and mRNAs are also reported to be involved. So just again to illustrate that you have primary and secondary genetic events, which takes you from normal plasma cells to MGUS to myeloma. But this all occurs against the background of the microenvironment in the bone marrow. And the myeloma cells are very, very dependent on this microenvironment. So first of all, the mutated plasma cell needs to home to the bone marrow microenvironment, and this happens through the interaction of chemokines and chemokine receptors, so CXCL12 and CXCR4. And then the other players in this very intricate bone marrow environment are the immune cells, the osteoblasts and the osteoclasts, bone marrow stromal cells, endothelial cells, and their extracellular matrix. And all sorts of growth factors, adhesion molecules, and cytokines play a role in this bone marrow microenvironment. For example, the cytokines that are very important, RANK ligand and RANK, as well as osteoprotegerin and MIF1 alpha, which leads to the imbalance of the osteoblasts and osteoclasts, which cause our lytic bone lesions. then vascular endothelial growth factor stimulates angiogenesis, which is also very important in myeloma. And last of all, we must actually remember that there's immune evasion. So hypogammaglobulinemia is another feature of myeloma and is associated with high risk. So if these myeloma cells are able to evade the immune system, they can lead to progression and increase their size. So that was a very brief and simplified overview of a very complex disease. Just wanted to add, in contrast, IgM-MGUS is a completely different story and most commonly progresses to Waldenström macroglobulinemia by definition if it's an IgM protein. You can get an IgM multiple myeloma, but that's exceedingly rare. So in contrast to myeloma, which doesn't really have one driver mutation, the MYD88 gene L265P is mutated in 93 to 97% of patients with Waldenström macroglobulinemia. And this gene is already mutated in 80% of patients with IgM-MGUS. And the presence of this mutation, as well as a high allelic burden, is associated with progression of IgM-MGUS. The other driver mutation that's quite exclusive to Waldenström is CXCR4, which is mutated in about 40%. And other than migration and homing of the cells to the bone marrow niche, it also plays a role in several other pathways that leads to this cancer. So very simplified, the development of monoclonal gammopathies, we really need to read from right to left. So multiple myeloma is almost always preceded by smoldering myeloma and non-IgM-MGUS. Waldenström macroglobulinemia is preceded by IgM-MGUS, which becomes a smoldering Waldenström macroglobulinemia, and then light chain myeloma is preceded by light chain MGUS, followed by smoldering light chain myeloma, previously called idiopathic Bench-Jones proteinuria. And these three conditions progress at different rates. So multiple myeloma, the progression from non-IgM-MGUS to myeloma is at about 1% per year. For Waldenström, the progression of IgM-MGUS is about 1.5% per year, and the lowest progressor year is light chain MGUS at about 0.3% per year. So as you can see here, a very long asymptomatic period is followed by the classic symptoms of these diseases. So the CRAB criteria for myeloma, Waldenström macroglobulinemia, which will present with hepatosplenomegaly and lymphadenopathy or hyperviscosity. And you might end up with kidney problems, nephrotic syndrome, and light chain deposition disease, or light chain or AL amyloidosis. So the problem here is that there's a very long time that goes by before the patient actually presents. And MGUS is something that's picked up when somebody decides to do a SPEP for some or other reason. The patient had a peripheral neuropathy or a high ESR, and they did it as part of the workup, and it ended up being that it wasn't actually the cause of the patient's symptoms, but in the meantime, they found this paraprotein. And if you decide to test for this, you're actually committing to following up this patient for the rest of their lives if it ends up being positive. This is a very good figure that just shows the disease progression in myeloma. So the monoclonal protein, which is demonstrated here on the y-axis, increases in size over a very long time, but it's not necessarily many years. The median progression in some studies have been shown to be about 8 years, 10 years, up to 20 years. But there have been cases where it was shorter, and it really just depends on where in the trajectory this test was done. So very simply put, you have an M protein that is still less than 30 grams per liter, but by the time it's more than 30 grams per liter, you have smoldering myeloma. If your bone marrow plasma cells are less than 10%, you still have MGUS, but by the time they are more than 10%, but less than 60%, it's smoldering. And then essentially by the time you have slim CRAB criteria, when you are symptomatic, you have myeloma. So we were still asking, why is it called MGUS? So monoclonal gammopathy was first described in the 1960s by Waldenström, who called it benign monoclonal gammopathy, and he truly believed that this was a benign disease. But then Robert Kyle coined the term MGUS in 1978. So Robert Kyle is a very prominent researcher who's still, you can find him on the website of the Mayo Clinic, and I'm sure it's called the Mayo Clinic because it's the Myeloma Clinic. They do very important research in this field. So in 1978 already, he coined this term for the first time, saying that we've been unsuccessful in determining which cases of monoclonal gammopathy without myeloma, macroglobulinemia, or amyloidosis will remain stable and which will progress eventually. That being said, with the methods available at the time, so SPE or SPEP and the percentage clonal plasma cells. So in 2023, the conundrum is still that most cases of MGUS remain stable over time, and only 1 out of 5 will progress to myeloma. However, all cases of myeloma are consistently preceded by MGUS. So who will progress and when? So Robert Kyle in the year 2002 did this study to determine the statistic that we still use today, that about the rate of progression is about 1% per year. But what was interesting is that this is not always a gradual, stable increase. It can be quite sudden, or it can be stable for a long time and then suddenly increase. So it's unpredictable to say who will progress and when. So how do we risk stratify patients with MGUS into 2023 and who will progress? So we have several models which are illustrated in this table. On the left-hand side, the most well-known and oldest classification is the 2005 Mayo Clinic study, which uses cutoff levels, which are for serum M protein of more than 15 grams per liter. If you have a non-IgG subtype of your M protein, or if you have an abnormal free light chain ratio. The 2014 Swedish study just added if you have immunoparesis, in other words, if you have hypoglobulinemia and your uninvolved immunoglobulins, that adds to your risk. And then the Spanish group in the Epithema study looked at other parameters. So they used the aberrant phenotype of bone marrow clonal plasma cells. If more than 95% of them had an aberrant phenotype, this was associated with high risk. And initially, they used DNA and iPLUD as a risk, and then they looked at the parameter, the evolution of your M protein essentially, and they said that if it increased by 10% or more after 2 years, that was also associated with an increased risk. So which risk stratification model is actually preferred? So let's look at it again in terms of our definition. So we want to look at the size of the M protein, the type, and the free light chain ratio. And that's the Mayo Clinic criteria, and that's actually quite easy to do. You only need to take blood and or urine. This is the figure from the 2005 study, which illustrated and risk stratified patients. And very clearly, you can see that when patients are risk stratified according to these criteria, they end up in very distinct subgroups, and we can try and predict their progression. But what about the size of the clone and the Slim Crab criteria? So this is what you will need for the Spanish study criteria. You actually need to do a bone marrow to then risk stratify these patients. And that's why most people actually use the Mayo Clinic criteria. However, while we're doing a bone marrow, how are we going to confidently exclude that you don't have any Slim Crab criteria or more than 10% clonal plasma cells? Do all patients with MGUS need a bone marrow and a whole body CT and perhaps a whole workup for amyloidosis? So here are some recent reviews on the topic. So 2 American blood reviews, 2018 and 2019, and then very recently published in May in the British journal, so the British guideline. So first of all, the American guideline, very trustworthy by this author Raj Kumar, who's almost the leader of the Mayo Clinic group now. So if a patient has MGUS, they are risk stratified, and if they are low risk and it's uncomplicated, they don't have any other suspicious clinical features, they suggest that you can actually defer bone marrow biopsy and skeletal survey. But anyone who is not low risk, in other words, anything more than a 0, if you have one of these criteria, they recommend that a bone marrow biopsy and a skeletal survey is done. And as we know, although it's not so easily available in our setting, that a whole body CT is actually much more sensitive than our X-ray skeletal surveys, and this will more confidently then exclude presence of lytic lesions. This is the 29 publication saying essentially the same thing. You risk stratify using Mayo Clinic criteria. If you have 0 risk factors, they do not recommend any further testing. However, if you have anything, risk factor and above, they recommend the following workup. So they do recommend a bone marrow biopsy with FISH. They recommend that for IgM MGUS, you do a CT to look for CT abdomen and chest to look for any lymphadenopathy that you might be missing. For non-IgM MGUS, they recommend the skeletal survey by CT again. And then in the case of light chain MGUS, and I will say a few words later about this, they actually recommend that you screen for amyloidosis. And then how do we follow up these patients? So this is just a very nice flow diagram to say that one must actually take into account the patient's life expectancy. So as we know, the median age of MGUS and myeloma is 69, 70 years. And if it takes about 20 years to progress, a patient who is 85 years old, the SPEP was done because he had lytic bone lesions from some other metastatic cancer, this patient is probably never going to survive long enough to actually develop multiple myeloma, and you probably do not need to follow him up at all. However, anyone who has a reasonable life expectancy will then be risk stratified, and if you're low risk, again, 0 criteria, you can actually follow up less frequently. However, it is recommended for everyone you're going to follow up after 6 months to see where are you, what is happening with this M protein and the other parameters you're looking at, where in this trajectory is the patient. So the higher risk patients, anyone that is not low risk, will then be followed up more frequently, 6 monthly for about 2 years to see what is happening. But if you are low risk, as we saw in those survival and progression curves, 5% risk of progression is very low over 20 years, and they can actually be followed up less frequently. The British are a little bit less conservative, and they only recommend this extensive workup for your high, intermediate, and high risk patients. So what do they recommend? They actually recommend that we screen everyone for AL amyloidosis, CT, to look for lytic bone lesions and bone marrow aspirate and creatinine, as well as just for a baseline LDH and beta-2 microglobulin. But then we must also remember that this risk stratification can change over time. This was illustrated in a recent study who followed up patients with MGUS to see if the risk stratification that they had at the beginning stayed the same or changed. And it makes sense that if a patient is progressing, that the risk can increase with time. So these risk stratification scores are not perfect because it gives an average risk of progression for all individuals with the score, and none of them actually provide an absolute risk for progression of the individual patient. So for you and your specific myeloma and its genomic characteristic, what is your risk of progression? And that we cannot say at this point. So the limitations is that it gives an actual average risk and not an individual risk, and it's based on tumor burden. So it's true that most cases that progress have a high tumor burden, but some individuals with a low disease burden will still progress to myeloma. And some individuals with a high disease burden never progress. So how are we going to identify these outliers? And Ola Landgren, in a recent paper, argues that this is an unmet clinical need, and unfortunately, our best tools for now are monitoring and reassessment. So the Mayo Clinic study was done in 2005. What have we learned in the last 18 years? So the same author, Ola Landgren, then proposes that we actually should be thinking of myeloma as 2 distinct precursor conditions, MGUS, which is truly benign, and early myeloma. And this is based on a study that looked at the whole genome. They did whole genome sequencing. And this study revealed that myeloma is actually preceded by 2 distinct entities. The early myeloma with a high-risk genetic signature versus the low-risk genetic signature of MGUS. And this is something that is not widely available for now, but maybe in the future we will be able to use our molecular knowledge to better stratify patients with MGUS. So that opens the next question. Should we actually be screening for MGUS to detect myeloma early? And this is an unanswered question. So there are 2 ongoing trials that are aiming to answer this question. A very large one that is being done in Iceland. It's called the iStop myeloma study. And these researchers in Iceland actually hoped to enroll the whole adult population in this study. So they actually managed to get about half of them, but this is a very small country and the population is only about 360,000 people. So we are hoping to, for the first time, screen everyone who's an adult to see, and they're doing lots of studies to see what associations are there with MGUS, who's progressing. The only problem is that in this population, it's obviously a small genomic pool. And the other thing is that it's probably biased towards Caucasians. So then there's another study that's going on in America called the PROMISE study. And as we know, the risk for MGUS and myeloma is about twice as high in Black people, or there were studies in Ghana. It's not just African Americans, it's actually Africans. And what these studies have shown us is that this increased risk is really probably not related to environmental factors, but to genetic ones. So they are also enrolling close family relatives of patients with myeloma or its precursor conditions. And this study might actually answer a question as to we should probably be looking at high-risk individuals for screening, if not everyone. So how common is MGUS? So the incidence is about 3% over the age of 50 years and 5% over the age of 70 years, and it's relatively common. It's more common in males than in females. And as we said, it's more common in Black people than white people. But there are more unknowns. How will early detection affect our treatment? And can we actually prevent any progression from MGUS to myeloma? So here we need to ask, when do we start treating the clone? So when I gave this talk in our department, I'm going to quote Dr. Gideon again, who talked about the line in the sand. So the only real line in the sand we draw for treatment is for active symptomatic myeloma defining events. However, it feels like this is a bit of a moving target and somewhat of a controversy. So in 2014, when the International Myeloma Working Group updated their criteria, they identified this ultra high risk smoldering myeloma patients who had the SLIM criteria. So if they had more than 60% clonal bone marrow plasma cells, if the involved to uninvolved free light chain ratio was more than 100, or if they had more than one focal lesion on MRI, their risk of progression to myeloma in the next 2 years was 80%. And so they were asking, why should we wait for people to jump off the cliff? Why can't we save them before they do? And then, as I'm saying, the target is moving. The next question is, what about high-risk smoldering myeloma? Should these patients not be treated? So there were 2 studies that tried to address this question. First of all, the Spanish BETHEMA group in 2013 were looking at lenalidomide dexamethasone versus observation only. And there was superior outcomes and increased survival in the treatment group. However, the problem with this study is there were a few, but the main problem was in this time, they didn't do skeletal surveys with CT. It was conventional x-rays. So the argument was that maybe some of these patients already had myeloma that was just not detected. So then the Americans in 2019 decided to do their own study, randomized controlled trial, and they used lenalidomide only, arguing that in the first study, maybe dexamethasone was how important is lenalidomide anyway? So they only looked at lenalidomide versus observation in high-risk smoldering myeloma. And here again, the outcomes were great in terms of survival and the primary endpoints and progression-free survival and overall survival. However, there were very high rates of adverse events, 40% grade 3 and 4 adverse events. And actually 50% of the lenalidomide arm stopped their treatment. So this is a problem. So we are taking relatively healthy patients and giving them very toxic drugs. So this is just lenalidomide, which we know is associated with a high risk of thrombosis, etc. We're not even talking about bortezomib and peripheral neuropathy. So many authors now recommend treating high-risk smoldering myeloma, but the answer is still open to discussion. So now I'm taking a step back. If we're saying how far can we move this line in the sands? What about MGUS? So if we're going to screen patients with MGUS, we probably need to offer some sort of treatment. So there are several clinical trials ongoing. First being a daratumumab trial, so the anti-CD38 monoclonal antibody in high-risk MGUS. They're looking at a cancer vaccine, the use of an antibiotic, and then I like this one, metformin. So how they decided on creating this phase 2 trial in metformin was they looked at patients with diabetes on metformin, and those who used metformin did not progress to myeloma as quickly as the patients who were not on metformin. And they probably targeted this group because obesity is actually associated with myeloma. But what they are postulating is that it's really not the glucose lowering effect of metformin, but some of the pleiotropic anti-inflammatory effects that might be helpful in this progression. But we'll see. So talking about treatment, what about the small but dangerous clone? And this brings me to the next part of this presentation. When is MGUS clinically significant? So for two reasons, MGUS can be significant. First of all, there are clinical associations, the most important ones being fractures, thrombosis, and infections. And then there's this new entity called monoclonal gammopathy of clinical significance. So the clinical association, fractures, has been demonstrated to be increased in patients with MGUS in a study, which included 488 patients. The mechanism is not quite clear, but ultimately it boils down to this imbalance of osteoclasts and osteoblasts, which alters your microarchitecture of your bony cortex. Thrombosis has been associated with MGUS. So patients, 1,491 patients developed venous thrombosis with MGUS. So this is also still a bit of an open question. Do they need treatment? Do they need lifelong treatment? Is prophylaxis recommended? So at this point, the association is not strong enough to actually give VTE prophylaxis to patients with MGUS. Then infections. Again, the association was demonstrated, but the risk overall was low and doesn't affect our management. But what about other associations? So this is one good study that came from the iStop myeloma study so far. So you will frequently see that MGUS is associated with autoimmune disease. But what they determined now is that if patients are actually screened for MGUS, there isn't an association with autoimmune disease. And those that were detected were actually in patients who presented to a clinic or to the hospital with autoimmune disease, and MGUS was detected. So this is really a form of detection bias. And the criticism against these other studies is that the association with fractures, infections, and thrombosis might actually just also be a selection bias. So we don't know for sure. And this brings us to the topic of monoclonal gammopathy of clinical significance. And to illustrate this point, I will now hand over to Caroline Steyn to present a case.
Thanks, Stephanie. Afternoon, everyone. I'm just going to present just a really short sort of summarized clinical case, just to kind of, give us a bit of a clinical angle, and then I'll hand back to Stephanie again to sort of take us further. But this was a patient that was referred to clinical hematology earlier in the year. It was a Mr. VS. Steph, I'm going to have to ask you to advance the slide, sorry. So this patient was a 67-year-old man with a background history of hypertension and intriguingly also Parkinson's disease, which may or may not tie into the topic. He was receiving, it says Karbilev at neurology, and he presented at internal medicine at our secondary level hospital with essentially with lower limb edema and with nephrotic range proteinuria, or subnephrotic range proteinuria, I beg your pardon, with a bland urine sediment and an impaired GFR. And sort of as one does at internal medicine, one sort of does a workup for this. And originally, sort of on his baseline workup, it was found that he had a normal full blood count, a normal calcium, and he was also normal glycemic with a HbA1c of 6.5%. He didn't have any significant viral serology. His autoimmune screen was also unremarkable. And in addition, he also didn't have any evidence of complement deposition or an ANCA-associated glomerulonephritis. Subsequent workup revealed that he did not have a paraprotein detectable, but he did have a very abnormal lambda light chain concentration in his serum, with a lambda predominance of 300, kappa of 33, which gives you a ratio of almost 10:1. And then a bone marrow was done sort of in the light of these findings and revealed a 10% clonal plasmacytosis, and importantly as well, no morphologic evidence of amyloidosis. So also on immunohistochemistry of the marrow, it was also the same pattern was found, it was lambda restricted. And essentially the question was what do we do now? So what further workup is needed? So he had a skeletal X-ray, which did not detect lytic lesions, although we've now sort of alluded to the limitations of this modality. So what was done next? So essentially, we were looking here for evidence of multiple myeloma or of amyloidosis, systemic light chain amyloidosis, given the fact that he had this lambda light chain. So a fat pad biopsy was done, which did not have there was no evidence of amyloid deposition there. A cardiac assessment was done, given the fact that he had this, lower limb edema, and he had a normal proBNP of 84. He had voltage criteria for left ventricular hypertrophy, which was probably in keeping with his antecedent history of hypertension. But had as well concentric left ventricular hypertrophy and a preserved ejection fraction. There were no signs of restrictive cardiomyopathy, but importantly, there wasn't really a comment on any abnormal strain patterns, because we know that in cardiac amyloidosis, one of the findings is basically an abnormal longitudinal strain pattern, which is probably quite difficult to assess. And the other important negative here was that diastology was also not really commented on. So that's something one would have to revisit here. And then the renal workup in this patient was on his 24-hour urine. He had no protein band detected, but free lambda was visible on immunofixation. It was too small to quantify, but he did have Bence-Jones proteinuria in the form of lambda light chain urea. And then the renal biopsy, given the fact that he had this almost nephrotic range proteinuria, is where it got more interesting. So on renal biopsy, this patient had basically linear positivity of IgG and C3 within the glomerular basement membrane. And then on glomerular assessment, he had sclerosis, and then in addition, mesangial thickening and remodeling and reduplication of the GBM, and then a moth-eaten appearance in other areas. There were also some deposits in the mesangium on the silver stain. And then in the light of the strong immunofluorescent positivity, the features were in keeping of pigment, essentially proliferative glomerulonephritis with monoclonal immunoglobulin Ig deposits with a membranous and MPGN involvement pattern. Subsequently, again, a very important sort of negative finding here was that this patient did not have any features of amyloid on his renal biopsy. There was also no evidence of light chain cast nephropathy, which is important here, and crystallopathy was also not present. So essentially, this picture was in keeping with a toxic tubulopathy, and the case was referred for kappa and lambda immunohistochemistry staining, which demonstrated again a lambda light chains in the tubular epithelium or epithelial cytoplasm. So this was the conclusion of light chain tubulopathy. And just to mention, the electron microscopy findings that were done at Tygerberg Hospital were just supportive of the microscopic features. So the end diagnosis, the final diagnosis, was that of a proliferative a pigment and toxic tubulopathy. So essentially, to summarize, we have a 67-year-old male with the following problems. If you want to sort of, try and rationalize something, it's good to write it all down and try and sort of see what supports your theory and what refutes it. So essentially, we had a patient with a lambda light chain monoclonal gammopathy. who did not fulfill criteria for smoldering myeloma or symptomatic multiple myeloma. However, a case can be made here that he has bone marrow lambda restricted clonal plasmacytosis with a really just on the threshold of 10%. So that, you know, you could still argue that this maybe, you know, can fit with the criteria of smoldering myeloma. It was actually reported as a little bit more, 10 to sort of 12%, if I remember correctly. So we are in that realm, but that does not mean that we can't diagnose monoclonal gammopathy of renal significance. He did not have any other myeloma defining events or crowd criteria, but I think that it would be prudent to do better imaging in this patient. And then we have this problem of the proliferative glomerulonephritis with monoclonal immunoglobulin deposits. So the assessment was that he has essentially got monoclonal gammopathy of renal significance, and we should bear in mind, as Stephanie has already explained, he's got an abnormal serum free light chain ratio. He's got a lambda light chain. We should be following this patient up as per the protocol that Stephanie showed us. The other intriguing thing with this patient was that he had this diagnosis of Parkinson's disease. So I was just wondering, I mean, I really didn't think about this prior to sort of preparing for this talk, but could this be related to his MGUS? And I found some case reports, albeit sort of not small, not really big series, but of patients with monoclonal gammopathies and tremors or movement disorders. So there was a case report in 2020 in the Annals of Movement Disorders. I'm not sure what the impact of that journal is, but nonetheless, there was a case report of immune-mediated chorea in a patient with kappa light chain monoclonal gammopathy. There was another case report of an IgM monoclonal gammopathy with neuropathy and tremor, and that was said to be a first sort of case control study in that to that effect. And then also this very interesting article about actually dopamine responsive tremor associated with gammopathy, also a case report. So, I mean, I don't know that this is really, we can't say for sure, but I just thought it was a very interesting clinical finding. We can just go back to the previous slide. Thanks. And then, so yeah, so there are these case reports, so it would be interesting to investigate that further. And then again, just his third problem was the hypertension with left ventricular hypertrophy. And we know that unexplained LVH does raise the suspicion for cardiac amyloidosis, but identification of LVH per se is not an indication to continue with a cardiac MRI. He didn't have any biopsy-proven amyloidosis elsewhere, so that was on renal biopsy and bone marrow and skin biopsy. But I think that cardiac amyloid still needs to be on the differential for heart failure with a preserved ejection fraction. And I would, in this patient, like to repeat his heart sono with just an expert assessment of this longitudinal strain pattern, have a look at his diastology, and really just do, we did do his proBNP, but I'd like to do his TROP-T as well. So yeah, that was sort of the problem list. And then the management for this patient essentially was that with MGRS, the point is that we know that these patients do not fulfill criteria for the diagnostic criteria for overt symptomatic myeloma or a lymphoproliferative disorder. But the feeling in sort of the absence of of proper randomized controlled trials is to essentially do clone-directed therapy, because you are trying to obviously optimize renal function, and also there's a role for improving renal function if the patient is going to have a renal transplant. That you now don't sit with the same problem after a renal transplant, that they've still got a small dangerous clone and develop MGRS in the transplanted kidney. So ideally you want to do bortezomib-based therapy, but due to the patient's age, the fact that he didn't automatically kind of qualify for a proteasome inhibitor in our setting, and due to cost constraint, we gave him a cyclophosphamide and dex regimen. And actually after 2 cycles, his renal function has already improved, and his lambda light chain total amount has decreased to 203. So just really very, very quickly, I don't want to take any more time, but just this is an up-to-date algorithm about treatment of proliferative GN with monoclonal Ig deposits. And essentially you have to decide, is there a detectable plasma B cell clone? If there is, the type is important, because if it's a plasma cell type, one needs to go with a bortezomib-based regimen. If it's a B cell type, you need a rituximab-based regimen. And if there isn't, then you need to sort of also assess whether there's detectable monoclonal protein in the serum or urine. If there is, then the isotype is important, and that also dictates treatment. But then also very importantly, if there isn't, the patient if the patient has AKI or subacute AKI and heavy proteinuria, then it's important again to still determine the isotype of the protein within the kidney deposits, and that again guides therapy. But if they don't have that clinical scenario, one needs to sort of then go for the conservative management approaches with antiproteinuric therapy, BP control. So sort of what you would do for any patient with heavy proteinuria. And then one does a response assessment based on that. So I think that's possibly my last slide. Stephanie, you can just go on. Okay, yeah. Okay, so I'll hand back to you.
Thank you very much, Caroline. So just for anyone out there who's confused, this patient has borderline 10% clonal bone marrow plasma cells, and that just really illustrates, again, this is a subjective assessment. So what's the difference between 9% and 11% plasma cells? But anyway, so he's here on the border, and he's got renal failure. So why is this not a myeloma defining event? So I just wanted to clarify that again, that the light chain cast nephropathy is the only myeloma kidney. So maybe just to refresh your memory, how light chain cast nephropathy works is the free light chains are filtered by the glomerulus, and then normally they are reabsorbed in the proximal tubuli. However, when the light chain concentration exceeds this resorptive capacity, these light chains will accumulate, and they will bind to uromodulin, which is the TAM-Horsfall protein. They will form casts, and these casts will cause obstruction in the distal tubules. They also lead to inflammation, tubular interstitial nephropathy with fibrosis, and this is your myeloma kidney. So this is excluded from the entity monoclonal gammopathy of renal significance. However, the nephrologists in 2012 came up with a solution for this problem and said, what about these patients with a paraprotein or light chains that are causing clinically significant problems? What about them? So they introduced the term monoclonal gammopathy of renal significance. And then in 2019, the definition was just a bit updated by the International Kidney and Monoclonal Gammopathy Research Group. So essentially, the definition of monoclonal gammopathy of renal significance is that when you do not meet the criteria for another plasma cell disorder or underlying B cell clone, so you don't have myeloma or related disorders, but you have an M protein which is causing one or more kidney lesions related to the immunoglobulin that is significant. That is monoclonal gammopathy of renal significance. And very briefly how they classify it, and this classification is really being adopted by the new term monoclonal gammopathy of clinical significance, which I will introduce, but they really look at the two mechanisms. Is it the monoclonal immunoglobulin that's being deposited, or is it complement related? And if there is deposition, they organize them into organized and non-organized lesions. So if it's fibrillar, such as amyloid, microtubular, so cryoglobulins, or if there's crystalline inclusions, and then the non-organized lesions are really your monoclonal immunoglobulin deposition disease, so light chain deposition disease, etc., or what our patient had, this progressive glomerulonephritis with a monoclonal immunoglobulin deposit. Okay, this is the same thing, just with some histology, and essentially this is a diagnosis that is made on kidney biopsy, and very much probably a problem for the nephrologist, but as you could see from Dr. Stein's case, the clinical hematologist may actually need to treat the patient, and from a laboratory perspective, we need to make sure that this patient does not actually have myeloma. So then in 2018, The term monoclonal gammopathy of clinical significance was introduced also by, as you can see, some of these famous authors, again from the Mayo Clinic, so the Myeloma Clinic. So what they were saying is that sometimes a small clone can be dangerous and it may actually warrant treatment. And they propose that this group of disorders is called monoclonal gammopathy of clinical significance. So we tend to think of MGUS as a small quiescent clone that's asymptomatic and you only need to monitor it. But it can be small and dangerous, it can cause organ damage, and it may require treatment. But it's not such a novel concept. These authors that actually co-authored that same paper that I just showed you already in 2006 published this paper on dangerous small B-cell clones, essentially describing the same things, just not as well structured as it is now. So what about monoclonal gammopathy of clinical significance in 2023? So in the WHO-HIM5, cold agglutinin disease is now included, and monoclonal gammopathy of renal significance. And I suspect that maybe in the next edition, this monoclonal gammopathy of clinical significance might show up. It's just that it's not as well defined for now, and there's a lot of unknowns. So what is monoclonal gammopathy of clinical significance? So there are two ways you can classify it, according to the pathophysiology, which is what this group did, and then possibly more simply just according to end organ involvement. And then I think we should also classify them according to the type of paraprotein, so IgM and non-IgM, because they can cause quite distinct problems. As illustrated in this table, some of the conditions that we will briefly discuss, the organs involved, the mechanism, and the type of immunoglobulin. So it can really involve a lot of organs, but most frequently it will involve the kidneys, the nerves, or the skin. And these are the mechanisms. So the immunoglobulin can be deposited in the tissues. It can have an autoantibody activity. It can activate complement. There can be cytokines involved. And then very interestingly, there's a couple of unknown mechanisms. So let's look at immunoglobulin tissue deposition. So this is organized in the same way as monoclonal gammopathy of renal significance. So we will look at some of these examples. So all of these immunoglobulin tissue deposition disorders can end up giving the same clinical picture. Most commonly, if the kidneys are involved, a type of nephrotic syndrome or just proteinuria for that matter, peripheral neuropathy and skin involvement. So in light of our patient where we were looking for the possibility of AL amyloidosis, I think it deserves a few words. I may have actually, yeah, that's fine. I skipped a picture there, but really what AL amyloidosis is, it's a protein folding disorder. So there's a small but dangerous plasma cell clone that secretes abnormally folded proteins. And these proteins then aggregate into amyloid fibrils. And the fibrils will then deposit in organs. So these amyloid fibrils are very stubborn. They are not soluble and they are very resistant to proteolysis. So they end up causing mechanical disruption in the organs. And the most important ones are the heart and the kidneys. But other than mechanical disruption, they actually exert some cytotoxicity. And this is really through upregulation of the p38 MAP kinase pathway, which also leads to elevation of pro-BNP. And that's why this marker is used as a surrogate to monitor cardiac involvement. So the clinical manifestations of AL amyloidosis, it can involve any organ but the brain. So it's said to be protean, which I think is a very good pun. So again, cardiac involvement with very typical features, this low voltage ECG pattern restrictive kind of cardiomyopathy, nephrotic syndrome, peripheral neuropathy. Now, these three common problems really looks like a patient with diabetes, and it's easily mistaken for that. But if you then do the sugar, as in our patient, again, borderline HbA1c, this can look like a patient with diabetes with micro and macrovascular problems, but it's actually due to amyloid. So amyloid is unfortunately an underdiagnosed disease that is missed very frequently. And one can think, oh, this is just hypertension, because hypertension is so common, causing this left ventricular hypertrophy. And if you're lucky, the patient will have this enlarged tongue or panda eyes. But unfortunately, although these signs are very sensitive, they're very specific, but they only occur in 15% of patients. So they're not very sensitive for picking up AL amyloidosis. So we actually need to have a high index of suspicion and look for amyloid. So in our patients with MGUS, as I said, there's not really consensus on should everyone's urine and cardiac markers be monitored routinely. But what we cannot excuse ourselves not to do is to look for these clinical features. So we need to look for patients with symptoms of heart failure, complaining of peripheral neuropathy. We can do a dipstick, so we can certainly have a low threshold. So, for example, also what also looks like diabetes is the autonomic neuropathy, of the complaining of diarrhea or gastric outlet kind of obstruction. So at this point, you will then go and look for amyloid. And the easiest way and quite non-invasive is the fat pad aspirate, which will actually exclude amyloidosis in 85% of cases. And this is just a fairly recent study where they, again, people from the Mayo Clinic were arguing that some invasive organ biopsies are being overused, and that the sensitivity of just looking at the bone marrow is 69%, and the fat aspirate was 75% in this study. But if you combined them, you had an 89% chance of actually diagnosing amyloidosis. The other problem is that you actually then need mass spectrometry to confirm your AL amyloidosis, but at least you will have found the problem in this way without going and biopsying a kidney or a heart. So this brings me to the second type of deposition disease, so cryoglobulinemia. So we get 3 types, and the M protein can be involved in type 1 and type 2. So what's the definition of a cryoglobulin? So this is an immunoglobulin that precipitates at a cold temperature, really less than 37 degrees, and then dissolves again upon rewarming. So MGUS, as well as other plasma cell disorders, are often associated with type 1. Type 2 is really most frequently associated with hepatitis C. So in a patient with type 2 cryoglobulinemia, one really needs to exclude that. But interestingly, there is a slight association with Waldenström macroglobulinemia and hepatitis C. So, and those patients also present with type 2 cryoglobulinemia. So how does it work? So type 1, in type 1, the M protein is the cryoglobulin. This is a immunoglobulin that will precipitate at a low temperature, and this happens in the small and medium-sized vessels, and this causes obstruction, and then this obstruction really leads to the symptoms, especially in the cold peripheries. It's very different from type 2 cryoglobulinemia. So here, the cryoglobulin is the complex, the immune complex that is formed between the monoclonal protein and the polyclonal proteins. So the M protein binds to the Fc receptors of the other immunoglobulins, the polyclonal ones, and form immune complexes. And these deposit in the vessels, actually causing a leukocytoclastic vasculitis, which is the result of complement activation. So this is quite a different mechanism, but clinically it looks essentially the same. So we always in our bone marrow reports, when we look at plasma cells and suspect myeloma, we mention that there are no crystalline inclusions. So what are these really? So crystalline inclusions are when the lysosomes, especially of the macrophages, do not degrade the light chains, they're resistant and they crystallize. And this can cause a crystal storing histiocytosis, which is really in the bottom pictures an accumulation of these crystal laden macrophages, which accumulates in organs. It can happen in the eye, and you can have a crystalline keratopathy. And if it happens in the kidneys, you end up with a renal tubular acidosis or Fanconi syndrome. So here, the proximal tubuli cells, the lysosomes, are unable to degrade the light chains. They then crystallize, and this leads to Fanconi syndrome. So what about the antibody activity? So the antibody or monoclonal protein can target several other proteins. For example, C1 inhibitor von Willebrand factor, lipoproteins, peripheral nerves, and then the big I or small I on the red cell. And we will briefly discuss these. So if C1 inhibitor is targeted by a monoclonal antibody, you can end up with acquired angioedema. So acquired C1 inhibitor deficiency has several causes, but this study showed that MGUS was actually reported in 30% of cases. Von Willebrand, acquired von Willebrand syndrome. So there are several mechanisms that can lead to acquired von Willebrand syndrome, but monoclonal immunoglobulin is one of them. And this can be in MGUS or, for example, in myeloma. So in MGUS and multiple myeloma, this mechanism is immune mediated. And one will make the diagnosis of acquired von Willebrand syndrome in a bleeding patient really with your von Willebrand studies. And the classic pattern in acquired von Willebrand syndrome is because there's increased clearance of von Willebrand factor, loss of these high molecular weight multimers. But what's important here is to identify the paraprotein if you've excluded the other causes, for example, shear forces and high platelets or other tumors, Wilms tumor, which absorb these von Willebrand factors. Actually, plasma cells are also thought to absorb them a bit. These patients, most of the time, actually get treated with desmopressin, which is not very effective because there's increased clearance and you just cause more release and it's cleared further. You want to replace the von Willebrand factor. However, if you have MGUS or paraprotein, you can give them Polygam. So this is quite important to recognize. Then if your M protein is directed against the lipoprotein, you can end up with this foamy macrophages in this xanthogranulomatosis lesions. So if a patient presents like this and they have a normal cholesterol level, you should think of necrobiotic xanthogranuloma, or I would say Erdheim-Chester disease. Then what about the peripheral nerves? So there's quite a few IgM-associated peripheral neuropathies. The most common being the anti-MAG antibody neuropathy associated with MGUS in 80% and Waldenström macroglobulinemia in 20%. And just to make sure everyone hasn't fallen asleep by now, I wonder if anybody in the audience would like to guess the diagnosis that is illustrated in this mnemonic that I'm showing here. The neurologists in the audience.
I doubt we have neurologists in the audience. I certainly don't think I would have gotten it, Stephanie. So I think you.
Okay, great. So this is a condition called CANOMAD syndrome. So CAN is for chronic ataxic neuropathy with ophthalmoplegia, IgM paraprotein, cold agglutinins, and dialysate antibodies. So at this point, I should probably say that all of these weird and wonderful things I'm showing are just that. They are super rare. And I hope we have a few minutes at the end to see if anyone has actually seen one of these conditions. Then complement activation, essentially in C3 glomerulonephritis and atypical hemolytic uremic syndrome. So the target here is actually not quite certain, but in some cases it's factor VIII. So complement-mediated or atypical hemolytic uremic syndrome, as you will all know, is really usually a genetic condition. So either you have a deficiency of your complement regulators, or you can have a gain-of-function mutation that causes high levels of C3. And if you cannot regulate your complement, your C3 convertase, it will end up with this amplification loop with complement, which really leads to a microangiopathic hemolytic anemia, microthromby. And the treatment of this, unfortunately, is supportive unless you're in the first world and you have access to emicizumab anti-complement therapies. However, in our setting, if you are lucky enough to identify an acquired antibody, if the patient has a SPEP and this is possibly against factor H, then one can offer them plasma exchange and immunosuppression. So it's something to keep in the back of your head. And the other thing is that these patients with the congenital deficiencies often only present in adulthood when there's a precipitating factor such as an infection, which leads to increased demand for your complement system. So then cytokine mediated classically is POEMS syndrome, and the cytokine involved here is vascular endothelial growth factor. But what is interesting here is that patients with POEMS are not actually treated with anti-VEGF antibodies. So bevacizumab doesn't actually work for them very well. But yeah, a few words on the small and dangerous clone of POEMS syndrome. So for POEMS syndrome, you will have a polyneuropathy, that's an essential diagnostic criteria, and a monoclonal gammopathy. And in this case, the heavy chain is usually IgA or IgG, almost never IgM, and it's almost always lambda restricted. Nearly all of them either have osteosclerosis or Castleman disease, and then they can have a variety of syndromes. So the POEMS mnemonic, as well as another one that's proposed for the other symptoms, is PEST. So POEMS PEST. PEST being for papilledema, extravascular volume overload, sclerotic bone lesions, and then a thrombocytosis or erythrocytosis. So POEMS syndrome also commonly involves the nerves and the skin. So a few words on the peripheral neuropathy in POEMS. It's a sensory neuropathy that is followed by a motor neuropathy. It's distal, symmetric, and progressive, and it actually leads to severe weakness, and over 50% that can end them up in a wheelchair. Autonomic symptoms, unlike amyloidosis, is not a feature. The S in POEMS for the skin lesions, we hear about skin lesions, but what are these actually? So an easy way to remember them is to look at the hands, the hair, the face, and the skin. So in the hands, they told us as undergraduate students in Talia O'Connor, there are only 5 things that cause clubbing, but this is not true. POEMS can also cause clubbing. The hair, hypertrichosis, the face, so lipoatrophy of the face, or just erythema. And then skin lesions, so also these probably related to the vascular endothelial growth factor, hemangiomas, and skin thickening. And then a group of very interesting disorders where the mechanism is actually unknown. So they can involve the skin, sometimes the skin and systemic features, and then a myopathy, which I will say a word or two on. So let's look at some of the skin lesions. So this is an interesting one, acquired cutis laxa. So this is related to an IgG monoclonal protein, and there's an elastin defect, and these patients present with these hound dog faces, and the patients I'm showing here, one was 40 years old, the other was 38 years old, and unfortunately there's not much you can do for these patients. They need plastic surgery to fix this. And here's another challenge for the audience, a small case of a patient, a 43-year-old presented with chronic urticaria, fevers, lymphadenopathy, arthralgia, and bone pain with the IgM kappa protein. So first of all, what is the diagnosis? And second of all, there's actually a clue. Oh, yeah, I gave the answer. So yeah, does anyone want to attempt a diagnosis?
Definitely, I think you'll have to give it to us.
Okay, so this is also one of those old...
I think we quickly read it, and I think many of these rare diseases none of us has seen, and
yes,
yeah, and yeah, but I think give us the answer.
Yeah, so maybe one day Schnitzler syndrome will show up on our doorstep or with the dermatologist. I don't know if anyone will be able to answer the second question. How is this urticaria different from the usual acute and chronic urticaria? So the clue here, so I'm just going to tell you actually, it's non-pruritic. So they have urticaria, but it's not pruritic. So Schnitzler syndrome. I think it's been known for many years, and Tendai Gutu, our clinic fellow, always says, I've never seen it, but it's probably seen me. Okay, so Schnitzler syndrome, autoinflammatory disease with a chronic non-pruritic urticaria and a monoclonal gammopathy, usually IgM kappa. 10 to 15% of them eventually develop IgM myeloma, or probably much less than 10 to 15, but most of them will go to Waldenstrom macroglobulinemia. Skin and systemic syndromes. So Tempe syndrome, like POEMS, is considered to be a paraneoplastic syndrome, not very well understood, and only a few cases ever reported. This is also if these patients end up in internal medicine and you make this diagnosis, people will be very proud of you. So a patient presenting to an emergency center in shock, but they don't have sepsis. So really there's a abrupt increase in vascular permeability, which leads to extravascular edema with hypovolemic shock and hyperalbuminemia and hemoconcentration. And this is called the systemic capillary leak syndrome. And this is often associated with IgG or IgA monoclonal proteins. And then this is also, I think this is a very important case to make the point. This is SLNOM, so sporadic late onset Nemelin myopathy associated with monoclonal gammopathy. So monoclonal gammopathy is even in the title here, but this is actually also seen in HIV. So this is a proximal myopathy, and this was a case report of a patient who presented with severe proximal muscle weakness and respiratory difficulties. And she actually required treatment. So she was treated with a stem cell transplant. Then she had Lendex maintenance, and she even relapsed and had Cyborg-D treatment as a third line of treatment. And you can see in the picture that she did improve. So I felt this was an excellent case to demonstrate how a small but dangerous clone can actually require a stem cell transplant in cases. But just to sum up, we've looked at monoclonal gammopathy of renal significance. Neurologic significance can be due to several disorders, amyloidosis, cryoglobulinemia, POEMS, and then the IgM-associated peripheral neuropathies. Skin involvement, some people refer to it as monoclonal gammopathy of cutaneous significance. This has been reviewed recently. If you want to refer to it, a whole group of interesting disorders, essentially due to the same mechanisms, deposits of immunoglobulins, antibody activity, cytokine secretion, or unknown mechanisms. And then last but not least, Jock, you can advise if you think we should start the discussion now or say a few words about cold agglutinin disease, which is really the other important small but dangerous clone.
Stephanie, I think you can continue with it. We've got 15 minutes, so I think it's worthwhile to touch on it. It is
okay.
important.
This is very timely. It's cold, and just for yourselves, I'm asking questions, but nobody needs to answer. It's just to get your attention, because nobody has a long attention span for an hour and a half. So what are the clinical signs here? So there's the clues. It's a cold front. So really we are sitting here with acrid cyanosis. Really that looks like it's bordering on gangrene, and livido reticularis, which is found in cold agglutinin disease. So remember, we distinguish between cold agglutinin disease and cold agglutinin syndrome. But some of the common symptoms are found in the skin in the peripheries. So Raynaud-like symptoms, acrocyanosis, livido reticularis. You can have ulceration and necrosis. And interestingly, if you swallow cold foods and liquids, they can have pain or discomfort or dysphagia, really. Or dinophagia is actually the term. So here are my questions for you guys, just to think about. True or false? Cold agglutinin disease is clonal lymphoproliferative disorder. That is true. Treatment with the new anti-complement drug sutimlimab was shown to be effective in reducing these cold-induced symptoms in A and B. That's false, and I will tell you why. Corticosteroids are the first line of treatment for cold agglutinin disease. It's false. Treatment of the underlying hematologic neoplasm is the most important step in the treatment of cold agglutinin syndrome. That is true. And a cold agglutinin titer of 64 at 4 degrees is expected to cause clinically significant hemolysis. Not expected, but it can. It's also true. Okay, so cold agglutinin disease, as you have seen now, is included in the new WHO, and it really deserves its place there because it's a clonal lymphoproliferative disorder. As this paper, I just included it because it had a nice title and nice pictures. There's been a lot of papers, but cold agglutinin disease, a distinct clonal B-cell lymphoproliferative disorder, and importantly, it has a distinct bone marrow picture. So we recently, actually last week, had a case which we are working up for a lymphoplasmacytic lymphoma. And we were asking this question, could this actually be just cold agglutinin disease? But that bone marrow was much more infiltrated by really B cells and lymphoplasmacytic cells with plasma cells. So in cold agglutinin disease, in the bone marrow, there will be these lymphoid nodules, and they can also be an interstitial infiltrate, but not a large interstitial infiltrate. And these clonal populations of B cells, there will be CD20 positive, is then often surrounded by plasma cells. That's how it's described. So this monoclonal disorder is really the result of a small B cell clone which secretes a IgM kappa cold agglutinin. So that's an antibody that's active, most active at 4 degrees, but if it's clinically significant, it can have a wide thermal range. So this leads to agglutination, especially in the cold body parts, the fingers, the toes, the ears, the nose, and it actually leads to complement activation. So the liver is very responsible for clearing the C3b coated red cells. So that's extravascular hemolysis. However, the terminal complement pathway can also be activated, leading to intravascular hemolysis. So this is then really the therapeutic targets in cold agglutinin disease. So first of all, you want to target the clone. So Berenson, if you see his name, he is the cold agglutinin, I don't know what to call him, god, and they recommend Ritex, bendamustine, or Benda's first line for frail patient Ritex monotherapy. And then this new drug, sutimlimab, C1 inhibitor for the hemolysis. And then as a last line, bortezomib, Ritex, fludarabine, FRC kind of based regimens. And then, as I said, these complement inhibitors, and not only do you want to target the clone, but the complement effects. And then, of course, the conservative measures, keep the patient warm, wear gloves, move to warmer temperatures, as they used to say. But Berenson argues that this is really now a disease that must be treated. So as I've said, it's an autoimmune hemolytic anemia mediated by a monoclonal cold agglutinin driven by an underlying clonal B-cell lymphoproliferation, and it doesn't fulfill the criteria for another B-cell lymphoma. So very importantly, this is MYD88 negative. And we will see more about this when the book is published. So just important to know, academically, we probably won't see this drug in a very long time, but the sutimlimab actually prevents hemolysis, activation of complement, but it doesn't have any effect on the agglutination. So it won't have any effect on the cold-induced symptoms. So just to illustrate again how IgM causes agglutination of red cells, and that has nothing to do with complement. That's really just agglutination in the acral body parts. This picture illustrates essentially what I've been saying, that there's complement activation, extravascular and intravascular hemolysis. And then we target the specific pathway. So sutimlimab acts here at activated C1s, and they are looking at several other drugs at different ways, targets in this pathway of complement. And this was illustrated in the Cadenza trial. It actually showed success rates in patients with cold agglutinin disease, reduced their transfusion requirements, reduced their anemia, reduced their hemolysis. So where this is available, this is very strongly recommended. And this is really just to emphasize that it doesn't act on the cold-induced symptoms. Remember that corticosteroids and splenectomy are useless in cold agglutinin disease. They should not be used. And as a last line, in some case reports, they have been used, but it's usually secondary to infection. So Berenson argues cold agglutinin disease is a definitely treatable disease. Patients with symptomatic anemia and bothersome cold symptoms should be offered treatment. They shouldn't just be told to wear gloves, to move. And non-pharmacologic management counts for patients with mild symptoms and compensated hemolysis. I showed this already. This is just to answer our other question, treatment of the underlying hematologic neoplasm. So if you've got a patient with cold agglutination, you need to make 100% sure that there's not actually a secondary cause. As we know, infections, autoimmune, and especially lymphoid malignancies, like our patient with suspected Waldenstrom macroglobulinemia. So we will treat the underlying condition. Just regarding the transfusion, one might want to consider keeping the patient warm. We spoke about this as well. Jacques said that a blood warmer isn't always the most brilliant idea because it can also cause hemolysis. maybe a bear hugger, making sure that the blood you're giving is also not just going to agglutinate again. Then the last question was a GALT glutenin titer of 64. It's expected to cause a significant hemolysis, and that is true. We have to really pay attention to our pre-analytical factors when we test patients with cold agglutinins. We need to draw the blood, keep it at body temperature, not allow it to cool down so it cannot agglutinate, and then do these tests. And in the patient we had, now not cold agglutinin disease, but syndrome, he actually had a very faint M protein. And it's actually recommended that if you're going to do a SPEP on these patients, the blood also needs to be kept warm at 37 degrees. So to summarize MGUS, what's the significance? MGUS should not be thought of as a benign disorder. 1% per year progress, but how do we predict who does? Monoclonal gammopathy of clinical significance includes a variety of conditions with paraprotein-related target organ damage that may require treatment. And yeah, that leaves us with a few minutes for discussion.
Stephanie, thank you. That really was a tour de force, and I think highlights a number of important issues. And I think probably the most critical thing for hematologists and any physicians in general is to know how to manage an MGUS, but also to be aware of, I think, an increasing range of clinical syndromes that may be associated with a monoclonal gammopathy or a underlying B-cell clone. I mean, not in all cold, for instance, not all cold agglutinin disease you'll have a monoclonal gammopathy. There may just be an underlying B-cell clone, but and I think the question, and some of these questions are, and you nicely showed us that not all the questions are not always haven't been answered. So, for instance, I mean, when do we target the clone? When do we go for therapeutic or supportive care, like, for instance, the acquired von Willebrand disease, where polygam may be useful, versus monoclonal gammopathy of renal significance, where we probably should be targeting the clone. Cold agglutinin disease or primary cold agglutinin disease, where we should definitely be targeting the clone. So yeah, I think it was a wonderful talk, and I think a lot of food for thought for all of us. And I think we've all probably seen patients with myeloma and maybe MGUS with weird clinical syndromes, which you can't put in a box. I was thinking of one of our myeloma patients who presented with extreme hyperkeratosis, and it was almost the most defining clinical feature, and this responded to his myeloma treatment. So yeah, these monoclonal proteins and small B-cell clones do interesting things, and sometimes they're well defined with a syndrome, but other times it may not be so straightforward. I'd like to open the floor for any questions. I think maybe just to go back to, there was this bit of a discussion about the whole issue of whole body low dose CT, where I think, and this is now more pertaining to diagnosing myeloma, but I think we should try and motivate our local radiologists to do whole body low dose CTs rather than skeletal overview. I see UCT have done so they've been able to get it implemented, and it's, I mean, in our setting it was mainly due to staff shortages, but yeah, I think that's what we should be doing rather than skeletal overviews, and it would make our workup and management or diagnosis of myeloma patients much easier if we have access to this. So I don't know if there's any other questions. I think, Stephanie, you're getting good feedback. I thoroughly enjoyed it, and I especially like the way that you divided up the proposed mechanism, and I think that was quite a useful slide. I think if this is posted on the website, that slide of thinking about the mechanisms of organ damage is quite useful as when you study for exams. I found that quite a useful slide. So thanks for that.
Jock, just on that point, sorry for interrupting. I just wanted to mention afterwards also that many of these conditions are also associated with the actual malignancies. So patients with Waldenström macroglobulinemia can have an acquired C1 inhibitor deficiency, etc. So yes, that classification applies to all the stages, really.
Yeah. Yeah, I think, I mean, obviously, always the principle is that when you have these, to rule out a defined malignancy that's got specific therapy. So, all right, I think we've reached the end of the time, and if there's no further questions, we can end there. Have a nice evening, everyone.
Thanks, Jock. Great stuff. Have a good evening.